Welcome to the Deep Dive. Our mission, as always, is to cut through all that complex information and really distill it down into the key nuggets of knowledge for you. Today, we're embarking on a pretty fascinating journey. We're going deep into the musculoskeletal and integumentary systems. And our guide for this is the really insightful Understanding Pathophysiology, 7th edition. Think about this. This is the machinery that lets you move, protect yourself, interact with the world. I mean, everything from the tiniest bone cell constantly working away to, the entire surface of your skin acting as your primary shield. So this session is really tailored for you, whether you're maybe prepping for an exam, getting up to speed in the medical field, or maybe you're just incredibly curious about how your own body works. We'll explore the fundamental structures, how they function, hopefully in harmony, and what happens when things inevitably go wrong. We'll look at both adults and children. It's going to be a pretty comprehensive look, trying to connect the dots, how these systems are built, how they maintain themselves, and how they respond to challenges. So just to lay the groundwork, what's our overall plan? What are we covering today?
Yeah, that's a great question. So today we're basically taking apart Unit 12 from the textbook. And this unit, it cleverly brings together two major systems. First, your musculoskeletal system, so that's your bones, your joints, your muscles. And second, the integumentary system, that means your skin, hair, and nails. Our goal is really to break down how these systems are constructed, look at the intricate cellular processes they use to maintain themselves, and then we'll dive into the fascinating and sometimes, challenging array of disorders that can affect them. We're talking everything from, common things like fractures to really debilitating forms of arthritis, widespread skin infections, chronic conditions, even, unfortunately, cancers. What's really key here, and a theme we'll definitely keep coming back to, is this idea of intricate balance. These systems need this incredible balance to perform their vital roles, mobility, protection, maintaining overall body stability, homeostasis. For instance, we'll see how just a slight tip in the balance of bone cell activity, that's crucial to preventing common conditions like osteoporosis. And we'll also really try to highlight how connected these seemingly distinct systems actually are. We want to give you a cohesive understanding, not just, isolated facts. It's all part of one big biological story.
Okay, great. Let's kick things off then with the framework itself, the musculoskeletal system. It's really, like you said, two systems working together. The skeleton bones and joints, and then all the soft tissues like muscles, tendons, ligaments. Each part plays such a crucial role in giving us mobility.
Yeah.
So first up, bones. We tend to think of them as, inert scaffolding, but they're really not like that at all, are they?
Absolutely not. Far from inert. Bones are incredibly dynamic, living tissues. They're constantly undergoing this process called remodeling. Think of it like a construction site that's running 24/7. Old bone is continuously being removed, and new bone is being laid down. And this vital process involves three main types of cells, each with a really specific job. First, you have the osteoblasts. Think of them as the bone builders.
The construction crew.
Exactly. They lay down this soft framework called osteoid, and then they're responsible for mineralizing it, turning that soft matrix into hard, strong bone. And this process is constantly being fine-tuned by things like hormones, like parathyroid hormone, PTH, and vital nutrients like vitamin D. Then there are the osteoclasts. These are the demolition crew.
Right.
These cells actively resorb bone, breaking down old or damaged bone tissue. They're absolutely crucial for maintaining bone strength, and also they help the body regulate calcium and phosphorus levels in the blood. And finally, we have the osteocytes. Now, these are interesting. They're actually transformed osteoblasts that get trapped within the mineralized bone matrix as it forms.
So they get walled in.
Sort of, yeah. Think of them as the foremen or maybe the sensors of the bone. They respond to mechanical stress, hormonal signals, and they essentially direct the osteoblasts and osteoclasts, the builders in the demo crew, telling them whether to build more bone or resorb some, making sure the matrix stays healthy and strong.
That's an incredible level of communication and constant activity just happening inside our bones. So if these systems are constantly remodeling, does that mean they're also particularly vulnerable if that delicate balance gets thrown off?
Right.
Maybe aging or disease?
Precisely. That balance between formation and resorption is absolutely critical, and it's tightly regulated by this really complex signaling pathway called the Opie-Drankel-Rank system.
Okay, Opie-Drankel-Rank.
Yeah, you can almost imagine it like a car's accelerator and brake system, but for your bones.
Yeah.
Their NKL, that's like the accelerator,
Yeah.
basically stimulates the demolition crew, the osteoclasts, telling them to increase bone loss.
Right, more breakdown.
Right. On the other hand, OPG is the brake. It binds to NKLL, physically stops it from activating those osteoclasts, and so it reduces bone loss and promotes bone formation. So the overall balance between RNK and OPG, which gets influenced by all sorts of cytokines and hormones, that determines how much bone you gain or lose.
Yeah.
And disruptions in this finely tuned system, well, that's really at the heart of many bone diseases.
That makes sense. It's all about balance.
Exactly. And structurally, bone comes in two main types. Both are present in every bone, just organized differently. About 85% of your skeleton is compact bone, or cortical bone. It's highly organized, very dense, solid, incredibly strong. It forms the outer shell of most bones.
Okay, the hard outer layer.
Yeah. The remaining 15% is spongy bone, or cancellous bone. Its matrix is arranged in this intricate network of bars or plates trabeculae. This makes it lighter, and it provides space for bone marrow where blood cells are made. Both types work together for the bone's overall strength and resilience.
So bones are these incredible self-repairing, adapting structures. But like we said, they wouldn't do us much good without joints to allow movement, would they? They'd just be static.
Exactly right. Joints or articulations are simply where two or more bones connect. Their main job is to provide both stability and mobility to the skeleton. And the amount of stability versus mobility really depends on the joint's specific structure. We can classify them broadly into three types based on what's connecting them. First, you've got fibrous joints. These are connected by dense fibrous tissue, like the sutures in your skull. They provide amazing stability, but allow minimal, if any, movement.
Right, like the skull plates.
Precisely. Then there are cartilaginous joints. These are connected by cartilage, either fibrocartilage or hyaline cartilage. The joints between your vertebrae are a good example. They offer slight movement, what we call amphiarthrosis, but still provide significant stability for the spine.
Okay, a little bit of give.
A little bit. Finally, we have the synovial joints. These are the stars of movement. They're the most movable and the most complex joints in the body. Think your knee, your shoulder, your hip. They're characterized by a fibrous joint capsule that encloses a space filled with fluid. And this synovial fluid is absolutely critical. It nourishes the articular cartilage covering the bone ends, and it allows for incredibly smooth, almost frictionless movement, like well-oiled gears.
That lubrication is key. And that smooth movement brings us right to the next critical component: skeletal muscles. These powerhouses make up a huge portion of our body weight. How do these intricate tissues actually work to generate force and create movement?
Yeah, skeletal muscles are amazing. They can make up, up to 40% of an adult's body weight. They arise from specialized cells called myoblasts. Each muscle is composed of millions of individual muscle fibers. These are basically single, long, cylindrical muscle cells. Now, a key functional concept here is the motor unit. This consists of a single motor neuron, a nerve cell coming from your spinal cord or brain, and all the muscle fibers it activates or innervates.
Okay, one nerve controlling multiple muscle cells.
Exactly. And the ratio matters. Muscles that need really fine, precise movements, like the ones controlling your eye movements, have a low innervation ratio. One neuron controls just a few fibers. Muscles that need more power and endurance, like in your calf, have a high innervation ratio. One neuron might control hundreds or even thousands of fibers.
Efficiency versus precision.
Kinda, yeah. Inside each muscle fiber, you then have bundles of even smaller structures called myofibrils. These are the real functional subunits, and these contain the major muscle proteins: actin, which forms the thin filament, and myosin, the thick filament. You can think of these like microscopic ropes, actin and little hooks, myosin. They interact directly, forming what we call cross bridges during muscle contraction.
Okay, the ropes and hooks model.
It's a good analogy. The entire muscle contraction process is this beautifully orchestrated four-step sequence. It starts with an electrical impulse coming to that motor neuron. That's excitation. This impulse triggers the release of calcium ions inside the muscle cell. That's coupling. These calcium ions are essentially the key. They unlock the interaction sites on the actin filament. Once unlocked, the myosin hooks can grab onto the actin and pull. This is the actual contraction, the shortening of the muscle. And this pulling action is highly energy dependent, requires a constant supply of ATP.
The body's energy currency.
Exactly. Then, for relaxation, the calcium ions are actively pumped back into storage, the hooks detach, and the muscle lengthens passively.
That's an incredibly precise dance happening at a microscopic level, millions of times over, just to, say, lift a coffee cup.
Yeah.
So we've got the bones providing the structure, the joints allowing the movement, and the muscles generating the force. What about the crucial connective tissues that hold it all together? The ropes and straps.
That's where tendons and ligaments come in. They play absolutely crucial structural roles. Tendons are these really robust, almost rope-like structures made mostly of collagen. They attach muscle to bone. Their main functions are, 1, to efficiently transfer the forces generated by muscle contraction to the bone, allowing you to actually move your skeleton. And 2, they also act as a kind of biological spring, absorbing shock and providing some stability.
Muscle to bone, got it.
Right. Ligaments, on the other hand, attach bone to bone. They are vital for forming and stabilizing joints, preventing excessive or unwanted movement. Think of them like strong, slightly flexible straps holding the joint together. Both tendons and ligaments are primarily composed of tough collagen fibers, but ligaments typically contain a bit more elastin, which gives them slightly more flexibility or stretchiness compared to tendons.
It's clear how robust this whole system is, constantly repairing itself, adapting. But like any complex machine, it's also constantly changing throughout our lives. What happens as we age? How does this amazing framework respond to the simple passage of time?
Yeah, aging significantly impacts the musculoskeletal system.
Mhm.
It leads to predictable, yet often manageable, changes across all its components. For bones, aging is generally accompanied by a progressive loss of tissue. They become less dense, less strong, and unfortunately more brittle. That intricate bone remodeling cycle we talked about, it slows down. Old bone tends to be removed faster than new bone is formed, especially after midlife.
The balance tips.
Exactly. Women, particularly after menopause, experience an accelerated rate of bone loss. This is primarily due to estrogen deficiency, which shifts that rank-lopage balance towards more osteoclast activity, more demolition. This dramatically increases the risk for fractures, particularly osteoporosis-related fractures. Men also lose bone mass as they age, but generally it happens at a slower rate and starts later in life.
Okay, so bones get weaker. What about joints?
In joints, age-related changes often include fragmentation or wearing down of the articular cartilage, that smooth cushioning tissue, and the synovial membrane, which produces the lubricating fluid, might thin out. This can contribute to stiffness, reduced range of motion, and sometimes pain, like in osteoarthritis.
And muscles. We hear a lot about losing muscle mass with age.
Yes, muscles also undergo significant changes. We typically start losing muscle mass in terms of both size and number of fibers around age 50. This process is called sarcopenia. It's linked to various factors, including reduced mitochondrial function, changes in the nervous system, hormonal changes, and sometimes reduced physical activity. We also see a decline in things like maximal oxygen intake and basal metabolic rate. But, and this is really important, muscle function remains highly trainable even into advanced age.
So it's not inevitable decline.
Not entirely. Maintaining physical activity, especially resistance training, is incredibly important for counteracting some of these age-related declines in muscle mass and strength. It emphasizes the importance of staying active throughout life.
Okay, that's a good overview of the normal structure and function and how it changes with age. Let's shift gears now and explore what happens when things go wrong in adults. Injuries and diseases can significantly impact mobility, quality of life. Let's start with fractures, perhaps the most immediate and often dramatic bone injury.
Right. Fractures are simply breaks in the continuity of a bone. They come in many, many forms, and we classify them based on several features, including their basic shape and their underlying cause. So we can think about them in a few key ways. Is it a complete fracture, meaning the bone is broken entirely into 2 or more pieces? Or is it incomplete, where the bone is damaged but still in one piece? Things like green stick fractures in kids fall into this category.
Okay, complete versus incomplete.
Then, is it open, also called compound, meaning the skin is broken, exposing the bone? This carries a much higher risk of infection. Or is it closed or simple, meaning the skin remains intact?
Makes sense. Infection risk is huge with open fractures.
Absolutely. We also describe fractures by the line of the break: linear, oblique, spiral, transverse. A comminuted fracture means the bone is broken into more than 2 fragments, often shattered. And then there are fractures related to stress or underlying conditions. Stress fractures are tiny microfractures, usually from repetitive abnormal stress like you see in athletes or military recruits. And pathologic fractures are particularly concerning. These happen at a site where the bone is already weakened by some pre-existing abnormality, maybe severe osteoporosis, a tumor, or a metabolic disorder. The break occurs with force that wouldn't normally harm a healthy bone.
So the bone is already compromised.
Exactly. Now, bone healing is a remarkably robust natural process. Sometimes, if the bone ends are perfectly aligned and held rigidly, often with surgical fixation like plates and screws, it can heal through direct healing or primary healing. No visible callus forms. More commonly, though, especially with casting, we see indirect healing or secondary healing. This involves the formation of a callus. What happens is, after the injury, a blood clot, a hematoma, forms. This triggers an inflammatory response. Then bone-forming cells migrate in and create a soft procallus made of cartilage and fibrous tissue. Over time, this procallus gradually mineralizes, becoming a harder bony callus that bridges the gap. Then, over months, even years, this callus is remodeled. Unnecessary bone is resorbed, and new bone strengthens along lines of stress, eventually restoring the bone's original shape and strength, more or less.
It's amazing how the body can rebuild like that.
It really is. Clinically, signs of a fracture usually include things like unnatural alignment or deformity, significant swelling, muscle spasm around the break, severe pain, and of course, decreased mobility or inability to use the limb. Treatment always involves two key steps. Reduction, which means realigning the broken fragments, getting them back into their proper position. This can sometimes be done manually, closed reduction, or might require surgery, open reduction. And the second step is immobilization, holding those fragments securely in place while they heal. This is typically done with a cast, a splint, traction, or internal fixation devices like pins, plates, rods, or screws, or sometimes external fixators.
Okay, so beyond bone breaks, what about issues with the joints themselves and the connective tissues, ligaments, tendons around them? These can be just as disruptive, right?
Oh, absolutely. Joint and connective tissue injuries are extremely common and can significantly impair function. We can have a dislocation where a bone is completely displaced from its normal position within a joint. The articulating surfaces are totally separated. Think of a dislocated shoulder. Or we can have a subluxation, which is a partial displacement. The bones are still in contact, but the alignment is off. Common sites include the shoulder, elbow, wrist, hip, and knee. Signs usually include pain, swelling, limited motion, and often a visible joint deformity. Treatment involves putting the joint back into place, reduction, followed by immobilization and then rehabilitation exercises to restore range of motion and strength.
Okay, dislocations and subluxations. What about strains and sprains? People use those terms all the time.
Yeah, they're very common soft tissue injuries. A strain is technically a tear or stretch injury to a muscle or its tendon. A sprain is a tear or stretch injury to a ligament.
Muscle tendon versus ligament. Got it.
Exactly. An avulsion is a specific type where the tendon or ligament pulls off a piece of bone at its attachment site. We classify strains and sprains by their severity. Grade 1 is a mild stretch, Grade 2 is a partial tear, and Grade 3 is a complete tear. Healing involves an inflammatory response, formation of scar tissue, collagen, and remodeling. It can take months to achieve full mechanical stability, especially with severe sprains or strains. Initial treatment usually follows the Price principle: protection, rest, ice, compression, and elevation. This helps manage pain and swelling. Then it's followed by appropriate support like bracing and a gradual rehabilitation program.
And what about chronic tendon issues, like tennis elbow?
Right. We also frequently encounter tendinopathy. This term is now preferred over tendinitis because often it's more about degeneration than pure inflammation. It's painful inflammation or, more accurately, degeneration within a tendon, often due to overuse and microtears. Conditions like tennis elbow, lateral epicondylopathy, or golfer's elbow, medial epicondylopathy, are classic examples of tendinopathy at the elbow. And then there's bursitis, which is inflammation of a bursa. Bursae are small, fluid-filled sacs that act as cushions between bony prominences and soft tissues like tendons or skin. Overuse or trauma can cause them to become inflamed, leading to pain and swelling. Managing these chronic tendon and bursal issues is evolving. While things like corticosteroid injections might offer short-term relief, there's growing interest in therapies aimed at stimulating tissue repair, like specific types of exercises, eccentric exercises, shockwave therapy, or even injections like platelet-rich plasma, PRP.
Okay. Muscle injuries can be widespread, but some conditions are particularly dangerous, true emergencies, because they involve significant systemic consequences or rapidly progressive local damage. You mentioned rhabdomyolysis and compartment syndrome earlier.
Indeed, these are absolutely critical conditions that require prompt recognition and urgent treatment. They can be limb-threatening or even life-threatening. Rhabdomyolysis, sometimes called rhabdo, is the rapid breakdown of skeletal muscle tissue. This breakdown releases large amounts of intracellular contents into the bloodstream. The most dangerous of these is a protein pigment called myoglobin. When myoglobin gets filtered by the kidneys, it can cause severe damage, leading to acute renal failure. This presence of myoglobin in the urine is called myoglobinuria, and it can make the urine look dark, like tea or cola.
What causes rhabdo?
The causes are diverse. It can be direct trauma, like a severe crush injury or extensive burns. Certain medications, particularly statins used for cholesterol, can trigger it in susceptible individuals. Alcohol abuse, toxins, severe infections, extreme heat stroke, and even incredibly vigorous, unaccustomed exercise can cause it. A key diagnostic marker is a massively elevated serum creatine kinase, CK level, often thousands or tens of thousands of units per liter, way above the normal range. Levels over 15,000 often indicate a very high risk of kidney failure. Treatment involves aggressive fluid resuscitation to flush the kidneys.
Okay, that sounds serious. What about compartment syndrome?
Compartment syndrome is another orthopedic emergency. It occurs when pressure builds up within a confined muscle compartment. These are groups of muscles surrounded by inelastic fascia. This increased pressure compromises blood flow to the muscles and nerves within that compartment. If blood flow is cut off, the tissues become hypoxic, starved of oxygen, and can die, necrosis, if the pressure isn't relieved quickly.
What causes the pressure increase?
It can result from bleeding or swelling within the compartment, often after a fracture, especially of the tibia or forearm. Crush injuries, prolonged external pressure, like lying unconscious on a limb, or even overly tight casts or dressings can cause it. The classic signs are often remembered by the 6 Ps. Pain, often described as out of proportion to the injury, deep, aching, and worse with passive stretch of the muscles in the compartment. Pressure, the compartment feels tense or hard to the touch. Pallor, pale skin, paresthesia, numbness or tingling, paresis, weakness or paralysis of the muscles in the compartment, and pulselessness, loss of distal pulse, though this is often a late and ominous sign.
The 6 Ps.
Recognizing it early is critical because irreversible muscle and nerve damage can occur within hours. Diagnosis often involves directly measuring the pressure inside the compartment with a needle device. If the pressure is high, the definitive treatment is usually emergency surgery, a fasciotomy, where the surgeon makes long incisions through the skin and fascia to relieve the pressure and restore blood flow. Untreated compartment syndrome can lead to permanent disability, chronic pain, and even necessitate amputation.
Wow, okay, critical stuff.
And it's one more related condition. A rare but extremely dangerous inherited muscle disorder called malignant hyperthermia, MH. This is a hypermetabolic reaction triggered in genetically susceptible individuals by certain inhaled anesthetics or a specific muscle relaxant called succinylcholine. It causes an uncontrolled massive release of calcium from storage within muscle cells. This leads to continuous, intense muscle contraction, rigidity, and extremely high body temperature, hyperthermia, metabolic acidosis, and rapid onset rhabdomyolysis. It's linked to mutations in genes controlling calcium channels in muscle. It can be fatal if not recognized immediately and treated quickly with a specific antidote called dantrolene.
Right. Okay, moving on from those acute critical conditions, let's explore chronic bone and joint diseases. These are often conditions that develop more gradually over time but can significantly impact quality of life. What are metabolic bone diseases, for instance?
Metabolic bone diseases are basically a group of conditions where the underlying problem is abnormal bone strength. This could be due to issues with mineral metabolism, calcium, phosphorus, problems with vitamin D, inadequate bone mass, or defects in the bone structure or quality. By far the most common bone disease globally is osteoporosis. The name literally means porous bone. It's characterized by low bone mineral density, BMD, and deterioration of the bone's microarchitecture. Essentially, old bone is resorbed faster than new bone is formed.
The balance is off again?
The balance is off. This makes the bones thinner, weaker, and much more susceptible to fractures, even from minor falls or stresses. The most common sites for osteoporotic fractures are the spine, vertebral compression fractures, the hip, and the wrist. Postmenopausal osteoporosis is a major public health concern. The decline in estrogen after menopause leads to increased bone turnover, with osteoclast activity demolition significantly outpacing osteoblast activity building. That epigrankle rank system we talked about is central here. Estrogen normally helps keep irisyl in check.
So estrogen is protective for bones?
Very much so. Diagnosis of osteoporosis typically involves measuring bone mineral density using dual-energy X-ray absorptiometry or DXA scans. The results are often reported as a T-score, comparing your density to that of a healthy young adult. Newer tools are also looking at bone quality, not just density. Treatment focuses primarily on preventing fractures. This includes lifestyle measures like adequate calcium and vitamin D intake, weight-bearing exercise, and fall prevention. Medications are also crucial, including bisphosphonates, which slow down osteoclasts, denosumab, a monoclonal antibody that targets AMKL, and sometimes agents that stimulate bone formation.
Okay, osteoporosis is the big one. What else falls under metabolic bone disease?
Another important category includes osteomalacia in adults and its pediatric counterpart, rickets in children. These conditions are characterized by inadequate or delayed mineralization of the bone matrix, osteoid. So the bone builders, osteoblasts, lay down the osteoid framework, but it doesn't harden properly with calcium and phosphate. The most common cause, by far, is severe vitamin D deficiency. Vitamin D is essential for calcium absorption from the gut and for proper bone mineralization. This leads to an accumulation of soft, unmineralized bone, resulting in skeletal deformities like bowed legs and rickets, bone pain, muscle weakness, and an increased risk of fractures, sometimes called pseudofractures. Treatment primarily involves correcting the underlying cause, usually with high-dose vitamin D supplementation and ensuring adequate calcium and phosphorus intake.
So soft bones instead of porous bones. That's a good way to think about it. And then there's Paget disease of bone, PDB. This is the second most common bone disease after osteoporosis, though still much less prevalent. Paget disease involves localized areas of abnormal and excessive bone remodeling. It typically starts with a phase of frantic, excessive bone resorption by overly active osteoclasts. This is followed by a compensatory, but disorganized and accelerated phase of new bone formation by osteoblasts. The result is bone that is enlarged, architecturally abnormal, structurally unsound, often described as sclerotic, but weak and prone to deformities, like bowing of long bones, fractures, and pain. It can also lead to neurological problems if, for example, skull thickening compresses cranial nerves. The exact cause isn't fully understood, but likely involves genetic predisposition and possibly environmental factors, maybe even viral triggers. Treatment often involves bisphosphonates to slow down the excessive bone turnover.
Okay. What about infections actually in the bone? That sounds particularly serious and difficult to treat given bone structure. It is indeed very serious and can be challenging. Osteomyelitis is the medical term for a bone infection. It's most commonly caused by bacteria, particularly Staphylococcus aureus, but fungi, parasites, or viruses can also be culprits. The infection can reach the bone in a couple of ways. It can be carried through the bloodstream from an infection elsewhere in the body. This is called hematogenous osteomyelitis. This route is more common in children, often affecting the rapidly growing ends, metaphyses, of long bones. In adults, hematogenous osteomyelitis often has a more insidious onset with vague symptoms. Alternatively, the infection can spread to the bone from an adjacent area of infection, like a diabetic foot ulcer, a surgical wound, or a traumatic injury with an open fracture. This is called contiguous osteomyelitis.
How does the infection behave once it's in the bone?
Once bacteria establish themselves in bone, they can trigger an intense inflammatory response. Pus forms and the pressure buildup can compromise blood supply to parts of the bone, leading to tissue death, necrosis. This dead bone is called sequestrum. The body tries to wall off the infection, sometimes forming a new layer of bone around the infected area called an involucrum. If the acute infection isn't completely eradicated with treatment, it can become subacute or chronic. Microorganisms can persist for years, often hiding within abscesses, sometimes called Brody abscesses, or within the necrotic sequestra, making them hard for antibiotics and immune cells to reach. The emergence of drug-resistant bacteria, especially methicillin-resistant Staphylococcus aureus, MRSA, has significantly increased the difficulty and severity of treating osteomyelitis. Diagnosis can be tricky. It often involves blood tests looking for signs of infection, like elevated white blood cell count, or inflammatory markers like CRP. Imaging studies, X-rays might be normal early on, but MRI or bone scans are more sensitive. And ideally, a bone biopsy to identify the specific causative organism and determine its antibiotic sensitivities. Treatment is typically prolonged and aggressive, usually involving long courses of intravenous and/or oral antibiotics, often for 4 to 6 weeks or longer, and frequently requires surgical debridement, the removal of infected and dead bone tissue. Sometimes hyperbaric oxygen therapy is used as an adjunct.
A tough condition to manage. Okay, we've covered quite a few bone disorders. Let's turn our attention now to joint disorders. Osteoarthritis is incredibly common, isn't it?
Yeah.
Something many people experience, especially as they get older.
Yes, osteoarthritis, OA, is by far the most common form of arthritis and a major cause of pain and disability worldwide, particularly in older adults, though it can affect younger people too, especially after joint injuries. It primarily affects synovial joints, knees, hips, hands, spine are common sites. Historically, OA was often viewed simply as wear and tear on the joints, but our understanding has evolved. While mechanical stress certainly plays a role, we now recognize it as a complex disorder involving the entire joint organ, including the cartilage, the underlying bone, subchondral bone, ligaments, synovium, and surrounding muscles. It involves biological processes, not just mechanical degradation. The hallmark pathological feature is the progressive loss and breakdown of articular cartilage, that smooth, white, cushioning tissue that covers the ends of bones within a joint.
So what's happening to that cartilage?
What happens is that the cartilage starts to soften, fray, and thin out. Erosion and fibrillation. Eventually, cracks and fissures can develop, and in severe OA, the cartilage can wear away completely, leaving bone rubbing directly on bone. This cartilage damage triggers changes in the underlying subchondral bone, which can become sclerotic, hardened, and develop cysts. Importantly, there's also often low-grade inflammation within the joint synovium. This is a more recently recognized key feature of OA pathogenesis, and the joint margins often develop bony outgrowths called osteophytes or bone spurs.
Okay, so it's more than just wear and tear. What are the typical symptoms?
The main clinical manifestations include joint pain, which is typically worsened by activity or weight bearing and relieved by rest, especially in the early stages. Stiffness is also common, particularly in the morning or after periods of inactivity, like sitting for a while. But this gelling stiffness usually lasts less than 30 minutes, which is a key point distinguishing it from inflammatory arthritis like AR-RO. Other symptoms can include joint swelling, effusion, tenderness to touch, crepitus, a grating or crackling sound or sensation with movement, and sometimes loss of range of motion or joint deformity. In lower extremity OA, like in the hip or knee, it can lead to a noticeable limp. Evaluation relies mainly on the patient's history and physical examination findings, often supported by x-rays, which can show characteristic features like joint space narrowing, indicating cartilage loss, osteophytes, and subchondral bone changes. Treatment focuses on managing symptoms, maintaining joint function, and ideally slowing disease progression. This usually involves a combination of non-pharmacologic approaches like exercise, weight management, physical therapy, assistive devices, and pharmacologic treatments like pain relievers, NSAIDs, sometimes joint injections. For severe end-stage OA, joint replacement surgery is often a very effective option.
Right. Beyond OA, which is primarily degenerative, you mentioned inflammatory joint disease, often just called arthritis. These seem to involve the immune system more directly.
Exactly. This category includes conditions where the primary problem is inflammation within the joint specifically, inflammatory damage or destruction occurring in the synovial membrane or the articular cartilage. This inflammation can be driven by infection or, more commonly in chronic arthritis, by non-infectious processes, particularly autoimmune mechanisms. Rheumatoid arthritis, RA, is the classic example of a chronic, systemic, autoimmune inflammatory joint disease.
Autoimmune meaning the body attacks itself.
Precisely. In Rhonay, the immune system mistakenly identifies the body's own tissues, primarily the synovial membrane lining the joints, as foreign and launches an attack against it. This triggers a cascade of inflammation within the synovium, synovitis. The synovial membrane becomes thickened, inflamed, and produces excess inflammatory fluid. A hallmark feature of RA is the formation of pannus.
Pannus, what's that?
Pannus is essentially an abnormal, thickened, invasive layer of synovial tissue that grows over the surface of the articular cartilage. It's packed with inflammatory cells, blood vessels, and enzymes like matrix metalloproteinases, MMPs, that actively digest and destroy the cartilage and even erode into the underlying bone. This pannus formation is a key driver of the joint destruction seen in RA. The inflammation involves altered immune signaling pathways, the release of numerous pro-inflammatory cytokines like interleukin-1, interleukin-6, and tumor necrosis factor alpha, TNF-alpha, and the recruitment of various immune cells into the joint.
And you said RA is systemic.
Yes, that's a crucial point. While the joints are the primary targets, RA is a systemic disease. The underlying inflammation can affect many other parts of the body, including the lungs, heart, blood vessels, eyes, skin, where characteristic rheumatoid nodules can form, and can cause general symptoms like fatigue, fever, and malaise. RA typically affects multiple joints, often in a symmetric pattern, meaning if one wrist is affected, the other one often is too. Common sites include the small joints of the hands and feet, wrists, elbows, knees, ankles, but can also affect shoulders, hips, and the cervical spine.
What are the typical signs and symptoms?
The onset is often insidious, starting gradually with vague systemic symptoms like fatigue and low-grade fever, followed by joint pain, tenderness, swelling, and stiffness. The morning stiffness in RA is typically prolonged, often lasting for an hour or more, which is quite different from the shorter stiffness seen in OA. Joints are often warm, swollen, and tender. Untreated, the chronic inflammation and joint disruption can lead to severe deformities, like ulnar deviation of the fingers and swan neck deformities. Diagnosis involves a combination of clinical evaluation, looking at the pattern of joint involvement, symptoms, blood tests for specific autoantibodies like rheumatoid factor, RF, and anti-citrullinated protein antibody, ACPA, which is more specific for RA, inflammatory markers like ESR and CRP, and imaging studies. Treatment has really advanced in recent decades. It focuses on controlling inflammation, relieving pain, preventing joint damage, and preserving function. This involves medications called disease-modifying antihematic drugs, DMARDs, like methotrexate, which is often a cornerstone of therapy. More recently, biologic DMARDs, BDMARDs, and targeted synthetic DMARDs have revolutionized treatment by targeting specific molecules or cells involved in the inflammatory process, like TNF inhibitors or JARAP inhibitors. Early diagnosis and aggressive treatment are key to preventing long-term disability.
Okay, RA is a major one. What other inflammatory joint diseases should we know about?
Another important one is ankylosing spondylitis, AS. This is also a chronic systemic autoimmune inflammatory disease, but it primarily affects the axial skeleton, particularly the sacroiliac SI joints, where the spine connects to the pelvis, and the spine itself. The inflammation in AS typically starts in the SI joints, sacroiliitis, and can gradually progress up the spine. It causes inflammation where ligaments and tendons attach to the bone in the situs. Over time, this chronic inflammation can lead to progressive stiffening and eventual fusion ankylosis of the vertebrae, potentially creating a rigid bamboo spine in severe long-standing cases.
Wow, fusion of the spine.
Yes. It can also cause inflammation in peripheral joints, like hips and shoulders, and enthesitis elsewhere, like at the heels. Importantly, ANS can also cause inflammation outside the musculoskeletal system, including uveitis, inflammation in the eye, inflammatory bowel disease, and sometimes heart problems like aortic regurgitation. Inflammation at the insertions of chest wall muscles can cause pleuritic chest pain. Diagnosis can be challenging early on, as back pain is common. MRI is very useful for detecting early sacroiliitis, often years before changes are visible on X-ray. Treatment involves physical therapy to maintain mobility and posture, NSAIDs for symptom relief, and for more severe or progressive disease, biologic response modifiers, particularly TNF inhibitors, are often very effective.
And what about gout? That seems different again.
Gout is quite different, yes. It's classified as an inflammatory arthritis, but the trigger isn't autoimmune in the same way as RA or AS. Gout is caused by an inflammatory response to an excess of uric acid in the blood, hyperuricemia, and in the synovial fluid of joints. Uric acid is a normal breakdown product of purines, which are substances found in our cells and in many foods, like red meat, organ meats, seafood, beer. Normally, the kidneys filter out excess uric acid and excrete it in urine. In people with gout, either they produce too much uric acid or their kidneys don't excrete enough of it, leading to high levels in the blood.
So the uric acid builds up.
Exactly. When uric acid levels in the synovial fluid become too high, supersaturated, it can crystallize out, forming needle-shaped monosodium urate MSU crystals within and around the joints. These crystals are seen by the body's immune system as foreign invaders, triggering an intense acute inflammatory response, a gout attack, or gouty arthritis. This typically causes sudden onset of severe pain, redness, warmth, and swelling in the affected joint. The big toe is the classic site for a first attack, a condition called podagra, but gout can affect other joints too, like the ankles, knees, wrists, and fingers.
Those attacks sound incredibly painful.
They are described as excruciating. Prolonged, untreated hyperuricemia and recurrent gout attacks can lead to chronic joint damage, gouty arthropathy, and the formation of tophi. Tophi are deposits of MSU crystals that form small, white, chalky nodules, often visible under the skin, typically around joints, in the earlobes, or along tendons. Gout progresses through stages: asymptomatic hyperuricemia, high uric acid, no symptoms; acute gouty arthritis, the attacks; intercritical periods, symptom-free times between attacks; and chronic tophaceous gout with persistent joint damage and tophi. People with gout are also at increased risk for kidney stones, uric acid stones, and kidney disease. Treatment aims to terminate the acute attacks quickly, often with NSAIDs, colchicine, or corticosteroids, reduce uric acid levels long-term to prevent future attacks and complications, using medications like allopurinol or febuxostat, which reduce uric acid production, or probenecid, which increases excretion, and manage contributing factors, often including dietary changes like reducing purine intake, avoiding alcohol, especially beer, and managing associated conditions like obesity and hypertension. Applying ice during an acute attack can also help.
Okay, that covers the major joint disorders. Finally, in this segment on adult musculoskeletal problems, let's explore disorders directly affecting the skeletal muscles themselves. From widespread pain syndromes to specific genetic defects, These can severely limit function.
Right. Muscle diseases, broadly termed myopathies, typically manifest with symptoms like muscle weakness, fatigue, pain, myalgia, cramping, or stiffness. We can see contractures, which refer to a lack of full passive range of motion in a joint. These can be physiologic, occurring temporarily without a muscle action potential, or pathologic, representing permanent shortening of muscle or connective tissue, often due to muscle spasticity resulting from central nervous system injury like stroke or cerebral palsy. Stress-induced muscle tension is common, often manifesting as neck stiffness, back pain, or headache. It's thought to involve increased activity in parts of the nervous system regulating muscle tone. Therapies like progressive relaxation training or biofeedback can be helpful. Then there's fibromyalgia, FM. This is a chronic, widespread musculoskeletal pain syndrome. It's characterized by diffuse joint and muscle pain, profound fatigue, increased sensitivity to touch, often identified by specific tender points, though diagnosis now focuses more on widespread pain and symptom severity,
Right.
and frequently associated with non-restorative sleep, cognitive difficulties, fibrofog, anxiety, and depression.
What causes fibromyalgia? It seems quite mysterious.
Its pathophysiology is still not fully understood, but it's considered a disorder of central pain processing or central sensitization. It likely involves a complex interplay of genetic susceptibility, environmental triggers like infection or trauma, alterations in neuroendocrine function like the stress response system, and changes in how the central nervous system processes pain signals, essentially amplifying pain perception. Diagnosis is based on clinical criteria, including a widespread pain index, WPI, and a symptom severity inventory, SSI. Treatment is highly individualized and usually involves a multidisciplinary approach, combining pharmacologic options like certain antidepressants or anticonvulsants, and non-pharmacologic strategies like patient education, exercise, cognitive behavioral therapy, CBT, stress management, and sleep hygiene.
Okay. And you mentioned chronic fatigue syndrome.
Yes, chronic fatigue syndrome, CFS, also known increasingly as myalgic encephalomyelitis, ME, is another complex, chronic, debilitating condition. Its hallmark is profound, persistent fatigue that is not relieved by rest and is often made worse by physical or mental exertion, post-exertional malaise. It's also typically accompanied by musculoskeletal pain, cognitive impairment, unrestful sleep, and other symptoms. Like fibromyalgia, it's thought to involve dysfunction in the central nervous system, immune system, and energy metabolism, possibly triggered by infections or other stressors in susceptible individuals. Diagnosis and management are challenging.
What about muscle loss from inactivity?
That's disuse atrophy, and it's a significant concern, especially in hospitalized patients or those immobilized after injury. It's simply the reduction in muscle fiber size, atrophy, after prolonged periods of inactivity like bed rest or having a limb in a cast. Muscle strength can decrease remarkably quickly, maybe around 3% per day just with bed rest. Prevention is key, including encouraging isometric contractions, tensing muscles without moving the joint, passive range of motion exercises, and, most importantly, restoring weight bearing and activity as soon as safely possible. We should also mention there are various inherited diseases of energy metabolism that specifically affect muscles. These occur when there's a genetic defect in one of the pathways muscles use to produce ATP energy. Examples include glycogen storage diseases like McArdle disease, where muscles can't break down glycogen properly, leading to exercise intolerance, cramps, and fatigue. Or Pompe disease, where glycogen accumulates within lysosomes. There are also disorders affecting lipid metabolism, like carnitine palmitoyltransferase 2 CPT2 deficiency. These often present with exercise-induced muscle pain or rhabdomyolysis.
Muscles can get infected too.
Yes, muscles can suffer from infectious myositis. This can be caused by viruses like influenza or Coxsackie virus, bacteria like S. aureus, often leading to abscesses called pyomyositis, or parasites like Trichinella. These infections typically present with muscle pain, tenderness, swelling, inflammation, and often elevated CK levels. There's also a group of autoimmune muscle diseases called idiopathic inflammatory myopathies, IIM. These include polymyositis and dermatomyositis. Dermatomyositis is distinguished by also having characteristic skin rashes, like a purplish rash over the eyelids or knuckles. Both cause progressive weakness, primarily affecting the proximal muscles, shoulders, hips. Inclusion body myositis is another type, typically affecting older adults and causing weakness in both proximal and distal muscles like fingers and wrists. Finally, like bone, muscle tissue can also develop tumors. These can be benign, like rhabdomyomas, or malignant rhabdomyosarcomas. Rhabdomyosarcoma is actually the most common soft tissue sarcoma in children. In adults, osteosarcoma remains the most common primary malignant bone tumor, often found in the bone marrow cavity near the ends of long bones in young adults. Chondrosarcoma is a malignant tumor of cartilage-forming cells, more common in middle-aged and older adults, often infiltrating spongy bone.
Okay, that's a comprehensive look at adult musculoskeletal disorders. Now, let's shift our focus specifically to children. Their growing bodies face a unique set of challenges, right? Specific injuries, developmental issues that we don't typically see in adults. Let's explore some of these, maybe starting with common foot and hip abnormalities.
Absolutely. Pediatric musculoskeletal health is a distinct field precisely because children are growing and developing. Their bones, joints, and muscles have unique characteristics and vulnerabilities. One relatively common congenital abnormality is clubfoot, the medical term being talipes equinovarus. Here, the infant is born with one or both feet turned inward, inverted, and downward, adducted, with plantar flexion. It looks twisted. The good news is that treatment has been revolutionized by the Ponseti method. This involves gentle manipulation and serial casting, where a series of casts are applied weekly, gradually correcting the deformity over several weeks or months. It's highly effective and often avoids the need for major surgery, though a minor procedure to lengthen the Achilles tendon, Achilles tenotomy, is often required near the end of casting. After casting, wearing a special brace, mostly at night, is crucial, usually until about age 3 or 4, to prevent the deformity from recurring.
So early intervention is key there.
Very much so. Another significant condition requiring early detection is developmental dysplasia of the hip, TDH. This isn't a single defect, but rather a spectrum of abnormalities in the development of the hip joint involving the femoral head, the ball, the acetabulum, the socket, or both. It can range from mild instability or shallowness of the socket to complete dislocation of the hip. Early diagnosis is absolutely critical for the best long-term outcomes, ideally within the first few months of life before the child starts walking. If it's missed, it can lead to premature arthritis, pain, and limb length discrepancy later in life. Healthcare providers screen for DDH in newborns and infants using specific physical examination maneuvers, most notably the Barlow maneuver, which attempts to dislocate an unstable hip, and the Ortolani maneuver, which attempts to reduce a dislocated hip. Ultrasound is often used in infants under 6 months to confirm the diagnosis, while X-rays are used in older infants and children. Treatment depends on the child's age and the severity of the dysplasia. In newborns, it often involves using a harness, like the Pavlik harness, to hold the hips in a flexed and abducted position, encouraging the socket to develop properly. In older infants, or if the harness fails, closed reduction under anesthesia followed by casting, a spica cast, might be needed. In some cases, open surgical reduction is required. The goal is always to achieve and maintain a stable, centered hip joint to allow for normal development.
And what about osteogenesis imperfecta? That sounds quite serious.
Yes, osteogenesis imperfecta, OI, often called brittle bone disease, is an inherited genetic disorder that primarily affects collagen synthesis. Collagen is a crucial protein for bone structure and strength. In OI, mutations, most commonly in the genes for type I collagen, lead to either insufficient amounts of normal collagen or the production of abnormal collagen. The result is bones that are extremely fragile and fracture very easily, often with minimal or no apparent trauma. There's a wide range of severity in OI, from mild forms with only slightly increased fracture rates to severe, life-threatening forms where fractures occur even before birth. Other features can include blue sclerae, the whites of the eyes appearing blue, hearing loss, dental problems, and short stature. Management is multidisciplinary, focusing on fracture prevention and care, maximizing mobility and function with physical therapy and sometimes orthopedic surgery like placing rods in long bones, and managing associated complications. Bisphosphonates are sometimes used to increase bone density, but they don't correct the underlying collagen defect.
Children can also get bone and joint infections, which you mentioned can behave differently than in adults due to their growing bones.
Yes, that's right. Infections like osteomyelitis and septic arthritis can be particularly challenging in children. Osteomyelitis in children, particularly the acute hematogenous type, spread through the bloodstream, often begins as an abscess in the metaphysis of a long bone. That's the area near the growth plate where the blood supply is rich and sluggish, making it easier for bacteria to settle. The infection can spread through the bone cortex, lift the periosteum, the membrane covering the bone, and potentially track into the joint space, especially in infants where blood vessels cross the growth plate. The body tries to wall off the infection, sometimes forming that shell of new bone, the involucrum around the dead bone, sequestrum. As we mentioned, the rise of community-acquired MRSA has significantly increased the morbidity and potential for severe complications from osteomyelitis in children. Early diagnosis and aggressive antibiotic treatment, sometimes with surgical drainage, are essential.
And septic arthritis.
Septic arthritis, a bacterial or sometimes granuloma disinfection within the joint space, is considered a true surgical emergency in children. Why? Because the inflammatory enzymes released by bacteria and the body's own immune response can rapidly destroy the articular cartilage, leading to permanent joint damage and long-term disability within just a few days if not treated promptly. The hip and knee are the most commonly affected joints in children. It's often caused by S. aureus, including MRSA, but in younger children, under 4 years, Kingella kingae is increasingly recognized as a common cause. Children typically present with fever, joint pain, swelling, warmth, and refusal to bear weight or move the affected limb. Diagnosis requires prompt evaluation, including blood tests for inflammation, imaging, like ultrasound or MRI, and most importantly, joint aspiration, drawing fluid from the joint to analyze for white blood cells, bacteria, gram stain and culture, and crystals. Treatment involves urgent surgical drainage and washout of the joint, arthrotomy or arthroscopy, and intravenous antibiotics.
What about inflammatory arthritis in kids like JIA?
Juvenile idiopathic arthritis, JIA, is the most common type of chronic inflammatory joint disorder in children. It's not just a single disease, but an umbrella term for several subtypes of arthritis that begin before age 16, persist for at least 6 weeks, and have no other known cause. JIA differs significantly from adult rheumatoid arthritis in its presentation, subtypes, and prognosis. It's characterized by persistent joint pain, swelling, stiffness, and loss of motion. Unlike adult RA, JIA often affects large joints like knees and ankles more commonly than small joints, although polyarticular forms resemble adult RA more closely. The main subtypes are based on the number of joints involved in the first 6 months. Pauciarticular, ligor articular, 4 fewer joints, polyarticular, 5 or more joints, and the presence of systemic features. Systemic onset JIA, characterized by high fevers, rash, and organ involvement. Some children with JIA test positive for rheumatoid factor, RF-positive polyarticular JIA, which often indicates a more severe, lifelong course similar to adult RA. A major concern in JIA, especially the oligoarticular subtype, is the risk of asymptomatic eye inflammation, uveitis, which can lead to blindness if not detected and treated early. Regular eye exams by an ophthalmologist are crucial. Treatment is supportive and aims to control inflammation, relieve pain, prevent joint damage and deformity, and maintain function. This typically involves NSAIDs, intra-articular corticosteroid injections, and often DMARDs like methotrexate. Biologic agents are used for more severe or resistant disease.
Okay. What about conditions specifically related to the growth process itself? Children's bones are actively growing, which must create unique vulnerabilities. You mentioned osteochondrosis earlier.
That's right. The period of rapid growth during childhood and adolescence creates specific areas that are susceptible to injury or disruption. Osteochondroses are a group of disorders affecting the growth centers, epiphyses or apices, of bones in growing children. They're generally thought to be caused by a vascularity and insufficient blood supply to these rapidly growing areas, often triggered by trauma, repetitive stress, or other unknown factors. This lack of blood flow leads to death of the bone tissue, osseous necrosis. The body then undergoes a slow, natural process of repair involving resorption of the dead bone and gradual replacement with new, live bone, revascularization, and reossification.
So the bone dies and then regrows.
Essentially, yes. But the process can take months or even years, and during this time, the affected bone is weakened and susceptible to deformity if not managed properly. A classic example is Legg-Calvé-Perthes, LCP disease. This is an osteochondrosis affecting the femoral head, the ball part of the hip joint. The blood supply to the femoral head gets interrupted, leading to necrosis. It typically affects children between the ages of 3 and 10, more commonly boys. Children usually present with a limp and pain, which might be felt in the hip, groin, thigh, or even referred to the knee. Treatment aims to contain the femoral head within the acetabulum socket while it heals and remodels, preserving its shape and preventing long-term deformity and arthritis. This often involves activity modification, anti-inflammatory medications, physical therapy, and sometimes bracing or surgery. Other common osteochondroses include Osgood-Schlatter disease, which affects the tibial tubercle, the bump just below the kneecap where the patellar tendon attaches. It causes pain and swelling, often in active adolescence during growth spurts, due to repetitive stress and pulling on the cartilaginous growth plate, apophysis. Seborrheic disease is similar but affects the calcaneus heel bone apophysis. These are usually self-limiting and managed conservatively with rest, ice, stretching, activity modification, and anti-inflammatory medications until the growth plate closes.
Okay. And scoliosis is another growth-related issue, right?
Yes, scoliosis, which is a sideways rotational curvature of the spine, is another significant condition often detected during childhood or adolescence. We differentiate between non-structural scoliosis, where the curve is flexible and corrects when the person bends sideways or lies down, often caused by factors outside the spine itself, like poor posture or a difference in leg length, and structural scoliosis, where the curve is fixed and involves vertebral rotation. Structural scoliosis can be idiopathic, the most common type with no known cause, congenital due to vertebral malformations present at birth, or neuromuscular, associated with conditions like cerebral palsy or muscular dystrophy. Small curves often just require monitoring. However, progressive curves, especially those over 20-25 degrees in a growing child, often require treatment to prevent further worsening during the adolescent growth spurt. The mainstay of non-operative treatment is bracing, typically worn for many hours a day until skeletal maturity. Bracing aims to halt or slow curve progression, but it doesn't usually correct the existing curve. For more severe curves, generally over 45-50 degrees, or those that continue to progress despite bracing, spinal fusion surgery may be recommended to correct the deformity and prevent further progression and potential long-term problems like back pain or respiratory issues.
And unfortunately, children can also experience more serious genetic conditions affecting muscles and also malignant tumors, which can be quite distinct from adult cancers.
Yes, these are particularly challenging and often devastating conditions. There's a group of inherited neuromuscular disorders that specifically affect children, causing progressive muscle fiber loss and weakness. Duchenne muscular dystrophy, DMD, is the most common and one of the most severe childhood neuromuscular disorders. It's an X-linked recessive condition, meaning it primarily affects boys, caused by mutations in the gene that codes for the protein dystrophin.
Dystrophin, what does that do?
Dystrophin acts like a shock absorber, connecting the internal muscle fiber components to the cell membrane and stabilizing it during muscle contraction. Without functional dystrophin, the muscle fibers are fragile and easily damaged during normal activity. They tear, die off, and are gradually replaced by fat and fibrous connective tissue, pseudohypertrophy, especially seen in the calves. Children with DMD typically present around age 3 to 5 with progressive muscle weakness, leading to difficulties with running, jumping, climbing stairs, frequent falls, a characteristic waddling gait, and often the Gower sign, where they use their hands to climb up their legs to stand up from the floor. The weakness progresses relentlessly, leading to loss of ambulation, respiratory muscle weakness, and cardiomyopathy. Diagnosis is confirmed by genetic testing for mutations in the dystrophin gene. Treatment is multidisciplinary and supportive, including corticosteroids, which can slow progression somewhat, physical therapy, respiratory care, and cardiac management. Excitingly, newer treatments like gene therapy and exon-skipping therapies are showing promise in clinical trials.
That sounds incredibly difficult for families.
It is. Another important neuromuscular disorder is spinal muscular atrophy, SMA. This involves the progressive degeneration of motor neurons in the spinal cord, leading to muscle weakness and atrophy, affecting motor skills. The severity varies greatly depending on the type. Like DMD, gene-based therapies are rapidly evolving for SMA and making a profound impact on prognosis, especially when started early. Myotonic muscular dystrophy, MMD, is another inherited multi-system disease that can present in infancy with severe, life-threatening breathing and swallowing problems, congenital MMD. Or it can manifest later in childhood or adolescence with muscle weakness, stiffness, myotonia, and problems in other organs. Regarding malignant bone tumors in children, osteosarcoma, as we mentioned, is the most common. It typically arises near the ends of long bones, metaphysis, often around the knee, during periods of rapid growth in adolescence. It frequently presents with localized pain, especially night pain and swelling. Osteosarcoma has a high propensity to metastasize, particularly to the lungs. Treatment typically involves a combination of multi-agent chemotherapy and surgical resection of the tumor, often with limb salvage surgery if possible. Ewing sarcoma is another malignant bone tumor seen primarily in children and young adults. Finally, and sadly, we must briefly address non-accidental trauma, the IRAT, or child abuse, as a cause of musculoskeletal injury in children. Certain fracture patterns are highly suggestive of abuse, particularly in infants and young children who are not yet mobile.
What kind of patterns raise suspicion?
Red flags include fractures in infants who aren't walking yet. A femur fracture in a non-ambulatory child has a very high chance of being from that. Specific fracture types like corner or bucket handle, metaphyseal fractures caused by shearing forces from pulling or twisting, Posterior rib fractures from squeezing the chest, fractures of the sternum or scapula, and multiple fractures in different stages of healing are highly concerning. Any suspicion of NAT requires a thorough evaluation, including a skeletal survey, x-rays of the entire skeleton, careful documentation, reporting to Child Protective Services according to local regulations, and ensuring the child's safety. It requires a sensitive, non-judgmental approach focused on the child's well-being.
A very difficult but necessary topic. Okay, we've covered a tremendous amount on the musculoskeletal system. Let's now turn our attention outward to our body's largest organ, the skin, the integumentary system. It's easy, I think, to take our skin for granted. We see it as just a covering, maybe something cosmetic. But I suspect there's a whole universe of complex activity going on just beneath the surface, isn't there? Far more than just keeping our insides in. What are some of the perhaps surprising roles our skin plays?
That's a perfect way to phrase it. Our skin is so much more than just a wrapper. It's really a dynamic, complex, and absolutely vital organ system. It's our interface with the world. And yes, it's our largest organ, making up about 20% of our total body weight. Its primary, most obvious role is environmental protection. It acts as a physical barrier against microorganisms, harmful ultraviolet, UV radiation from the sun, excessive water loss preventing dehydration, and mechanical stress or injury. But its functions go way beyond just being a barrier. It's crucial for regulating body temperature through mechanisms like sweating, evaporative cooling, and controlling blood flow to the skin surface, vasodilation to release heat, vasoconstriction to conserve it. It plays a key role in immune surveillance. Specialized immune cells, like Langerhans cells in the epidermis, are constantly monitoring for pathogens or foreign substances. The skin is where vitamin D synthesis begins, activated by exposure to UV light. Vitamin D is essential for calcium absorption and bone health, as we discussed. And of course, it provides us with vital sensory input about our environment through a vast network of receptors for touch, pressure, temperature, and pain.
So it's a barrier, a thermostat, an immune outpost, a vitamin factory, and a sensor array all rolled into one.
Exactly. It's incredibly multifaceted. Structurally, the skin is composed of two main layers. The epidermis is the outermost superficial layer. It's relatively thin and avascular, no blood vessels. It's primarily made up of cells called keratinocytes. These cells produce keratin, a tough, fibrous protein, and they are constantly migrating upwards, eventually forming the outermost protective layer, the stratum corneum, which is composed of dead, flattened keratinocytes that continuously shed. The epidermis also contains melanocytes, which produce the pigment melanin, giving skin its color and providing crucial protection against UV damage. And those Langerhans cells we mentioned, which are part of the immune system. Beneath the epidermis is the dermis, often called the true skin. It's much thicker and provides the main structural support for the skin. It's rich in connective tissue containing fibroblasts, which produce collagen and elastin, macrophages, immune cells also called histiocytes in tissue, mast cells involved in allergic reactions, and an extensive network of collagen fibers providing strength and elastin fibers providing elasticity. The dermis is highly vascularized and contains nerves, hair follicles, and glands. It has two sublayers, the upper papillary layer and the deeper reticular layer. And beneath the dermis lies the subcutaneous layer, or hypodermis. This isn't technically part of the skin, but it anchors the skin to underlying tissues like muscle. It's composed mainly of loose connective tissue and adipose tissue fat, which provides insulation, cushioning, and energy storage. It also contains nerves, blood vessels, and lymphatic vessels.
Okay, epidermis, dermis, subcutaneous layer. What about things like hair and nails?
Right, those are considered dermal appendages, structures that develop from the epidermis and extend down into the dermis. These include nails, which are protective plates of hardened keratin that grow continuously from the nail matrix. Hair follicles, which are complex structures producing various types of hair, like fine vellus hair or coarser terminal hair, for functions like warmth, protection, and sensation. Each follicle is associated with an erector pili muscle, which makes hair stand on end, and usually a sebaceous gland. Sebaceous glands produce an oily substance called sebum, which lubricates the hair and skin surface, helping to keep it pliable and providing some antimicrobial properties. And sweat glands. There are two main types. Acrine sweat glands are found all over the body and are crucial for thermoregulation, producing watery sweat that cools the body through evaporation. Apocrine sweat glands are larger, found mainly in the axillae, armpits, groin, and around the nipples, and they produce a thicker, milky secretion that becomes odoriferous when broken down by skin bacteria. They become active at puberty and respond to stress.
And just like the musculoskeletal system, this intricate integumentary system undergoes significant changes as we age. We certainly notice our skin changing over time, don't we?
Yes, absolutely. The changes associated with aging skin are numerous and contribute to many of the visible signs of aging, as well as functional declines. The textbook often summarizes these as geriatric considerations. Generally, the skin becomes noticeably thinner, both the epidermis and the dermis. It also becomes drier due to decreased function of sebaceous and sweat glands, and of course, it becomes more wrinkled. Functionally, wound healing capability significantly decreases with age. Wounds take longer to heal, and there's a higher risk of complications like infection or chronic wounds. There's a decrease in the number of active melanocytes, leading to paler skin, and reduced natural protection against UV radiation. However, remaining melanocytes can sometimes enlarge or cluster, leading to irregular pigmentation like age spots, lentigines. The connection between the epidermis and dermis weakens. The rete pegs, which are downward projections of the epidermis that interlock with the dermis, flatten out. This makes the skin smoother and shinier in appearance, but also more fragile and prone to tearing from shearing forces.
Ah, that explains why older skin can tear more easily.
Exactly. There's also a loss of elastin and changes in collagen fibers, making them less flexible and more cross-linked. This loss of elasticity and resilience is a major contributor to wrinkling and the skin's reduced ability to stretch and bounce back. The barrier function of the stratum corneum, the outermost layer, also diminishes, making the skin more permeable and increasing the risk of dehydration and infection. As mentioned, atrophy of sweat and sebaceous glands causes dry skin, xerosis, which can lead to itching, pruritus. There's also a decrease in the number and sensitivity of nerve endings, leading to reduced sensory perception, including touch, temperature, and pain sensitivity. Temperature regulation becomes less efficient due to changes in skin blood flow and reduced sweating capacity, increasing the risk of both heat stroke and hypothermia in older adults. Nails also tend to become thinner, more brittle, and grow more slowly.
Okay, quite a few changes. Now let's look at how dysfunction manifests in the skin. Skin problems are so visible. How do clinicians start to identify and describe skin problems, maybe starting with lesions?
That's right, the visibility of skin conditions is unique. Identifying and accurately describing skin lesions is the absolute foundation of dermatologic diagnosis. We have a specific vocabulary to describe what we see. A key distinction is made between primary lesions and secondary lesions. Primary lesions are the initial basic lesions that represent the disease process itself as it first appears on the skin. Secondary lesions are those that develop later, either evolving from primary lesions or caused by external factors like scratching, infection, or treatment.
Okay, primary first, then secondary changes. Can you give examples of primary lesions?
Sure. Primary lesions are described based on their size, shape, elevation, and whether they contain fluid. Flat lesions. A macule is a flat, discolored spot less than 1 centimeter in diameter, like a freckle or a simple rash spot. A patch is just a larger macule, greater than 1 centimeter, like a birthmark or vitiligo. Raised, solid lesions. A papule is a small, elevated, firm bump less than 1 centimeter, like a wart or an insect bite. A plaque is an elevated, firm, rough lesion with a flat top, greater than 1 centimeter. Think of the characteristic lesions of psoriasis. A nodule is elevated, firm, and deeper in the dermis than a papule, typically 1 to 2 centimeters in size, like a lipoma. A tumor is just a larger nodule, greater than 2 centimeters. A wheal, like in hives or urticaria, is an elevated, irregular-shaped area of cutaneous edema. It's solid, transient, and variable in size. Raised, fluid-filled lesions. A vesicle is a small, elevated, superficial lesion filled with clear serous fluid less than 1 centimeter, like in chickenpox or herpes simplex. A bulla is simply a larger vesicle, greater than 1 centimeter, a blister. A pustule is similar to a vesicle but filled with purulent fluid, a pus, like in acne or folliculitis. A cyst is an elevated, circumscribed, encapsulated lesion filled with liquid or semi-solid material located in the dermis or subcutaneous layer, like a sebaceous cyst.
Okay, that's a lot of specific terms. What about secondary lesions?
Secondary lesions reflect changes over time or due to external factors. Examples include scales, heaped up keratinized cells like in dandruff or psoriasis, lichenification, roughened, thickened epidermis secondary to persistent rubbing or scratching, keloids and hypertrophic scars, excessive scar tissue formation, excoriations, loss of epidermis, linear hollowed out areas like from scratching, fissures, linear cracks or breaks from epidermis to dermis like athlete's foot. Erosions, loss of part of the epidermis, moist and glistening, often after rupture of a vesicle or bulla. Ulcers, loss of epidermis and dermis, concave. And atrophy, thinning of the skin surface. Beyond individual lesions, clinicians also look for other specific features like comedones, plugged hair follicles and acne, burrows, tunnels made by parasites like scabies mites, petechiae, tiny pinpoint non-blanching red-purple spots due to capillary bleeding, Purpura, larger areas of bleeding under the skin, and telangiectasia, fine irregular red lines produced by capillary dilation like spider veins.
That descriptive language is clearly vital. You mentioned pressure injuries earlier. That seems like a major problem, especially in healthcare settings.
Yes, pressure injury, the term now preferred over pressure ulcer or decubitus ulcer, is a very significant problem, particularly in individuals with limited mobility, like hospitalized patients, nursing home residents, or those with spinal cord injuries. It's defined as localized damage to the skin and/or underlying soft tissue, usually over a bony prominence, like the sacrum, heels, hips, elbows, resulting from intense and/or prolonged pressure or pressure in combination with shear forces. What happens is that the pressure occludes capillary blood flow to the tissue. If this pressure isn't relieved frequently, the tissue becomes ischemic, lacks oxygen and nutrients, and eventually necrotic dies. Shearing forces, like when a patient slides down in bed, can stretch and damage blood vessels, making the tissue even more vulnerable.
Who is most at risk?
Risk factors are numerous and include impaired mobility, impaired sensation, like in neuropathy or spinal cord injury, poor perfusion, due to vascular disease or low blood pressure, fecal or urinary incontinence, moisture macerates the skin, malnutrition, especially low protein, dehydration, and chronic diseases that affect tissue health. Pressure injuries are staged based on the depth of tissue damage, ranging from stage 1, intact skin with non-blanchable redness, to stage 4, full-thickness skin and tissue loss with exposed muscle, tendon, or bone. There are also categories for unstageable injuries where the base is obscured by slough or eschar, and deep tissue injury, persistent, non-blanchable, deep red, maroon, or purple discoloration. Prevention is absolutely key and involves meticulous skin assessment, frequent repositioning, turning schedules, using pressure-reducing support surfaces, special mattresses or cushions, managing moisture, and optimizing nutrition and hydration.
Okay. And keloids and hypertrophic scars, you mentioned those briefly.
Right. Both are types of excessive scar formation after skin injury, but they differ slightly. A hypertrophic scar is an elevated fibrous scar that remains within the boundaries of the original wound. A keloid is also elevated, but it grows beyond the borders of the original injury, invading surrounding normal skin. Keloids are more common in individuals with darker skin pigmentation and often occur after even minor trauma. Both result from excessive fibroblast activity and collagen deposition during wound healing. They can be itchy or painful and are often a cosmetic concern.
And itching pruritus, you said, is very common.
Extremely common. Pruritus, or itching, is a subjective sensation that provokes the desire to scratch. It's one of the most frequent symptoms in dermatology and can be associated with a vast number of primary skin disorders like eczema, hives, insect bites, psoriasis, scabies. But it can also be a manifestation of underlying systemic diseases such as chronic renal failure, uremic pruritus, liver disease, cholestatic pruritus, thyroid disorders, certain cancers, especially lymphomas, iron deficiency anemia, or even medications. Sometimes no underlying cause is found, idiopathic pruritus. The sensation of itch is transmitted by specific small, unmyelinated type C nerve fibers in the skin to the central nervous system. It's mediated by a complex interplay of various chemical substances released in the skin, including histamine, especially in hives, but also many others like prostaglandins, serotonin, bradykinin, neuropeptides like substance P, and cytokines. The urge to scratch can lead to a vicious itch-scratch cycle, where scratching provides temporary relief but causes further skin damage and inflammation, which in turn worsens the itching.
Inflammation seems to be a recurring theme in many skin disorders, suggesting the body's immune response is often playing a central, maybe even problematic role.
Indeed. Inflammation is at the heart of a huge number of skin conditions. Eczema and dermatitis are essentially interchangeable terms used broadly to describe patterns of inflammatory skin response. They aren't specific diagnoses themselves, but rather describe a clinical picture. This picture typically includes symptoms like pruritus, itching, lesions that often have indistinct borders, and characteristic epidermal changes such as erythema, redness, papules, small bumps, vesicles, small blisters, scaling or sometimes oozing and crusting in acute phases, or thickening lichenification in chronic phases.
So what are some common types of eczema or dermatitis?
There are several types. Irritant contact dermatitis, ICD, is very common and develops from direct damage to the skin barrier caused by prolonged or repeated exposure to irritating substances like strong soaps, detergents, solvents, or even just excessive water exposure. It's not an allergic reaction. Allergic contact dermatitis, ACD, on the other hand, is an allergic reaction. It's a delayed type-like hypersensitivity reaction mediated by T lymphocytes. It occurs after sensitization to a specific allergen, like poison ivy, nickel in jewelry, fragrances, preservatives, and cosmetics, and then re-exposure to it, causing an itchy, often blistering rash in the area of contact. Atopic dermatitis, AD, often just called eczema, is a very common chronic relapsing inflammatory skin condition. It typically starts in childhood and is often associated with a personal or family history of other atopic diseases like hay fever, allergic rhinitis, or asthma. It's linked to a combination of genetic predisposition, often involving defects in skin barrier proteins like filaggrin, immune dysregulation, often involving IgE antibodies, and environmental triggers. AD is characterized by intense pruritus, characteristic eczematous lesions, which look different in infants, children, and adults, and impaired skin barrier function, leading to dry, sensitive skin prone to secondary infections. Stasis dermatitis occurs on the lower legs, typically in older adults, as a result of chronic venous insufficiency, poor vein function, and edema, swelling. The increased pressure in the veins leads to leakage of fluid and blood cells into the tissues, causing inflammation, erythema, itching, scaling, brownish discoloration, hemosiderin staining, and eventually skin breakdown and ulceration, venous ulcers. Seborrheic dermatitis is another common condition, presenting with scaly, flaky, yellowish, sometimes greasy inflammatory plaques. It typically affects areas rich in sebaceous glands, like the scalp, causing dandruff in mild forms, face, eyebrows, eyelids, nasolabial folds, chest, and back. The yeast Malassezia is thought to play a role.
Okay. Then there are the papulosquamous disorders. What defines those?
Right. Papulosquamous disorders are a group characterized clinically by the presence of both papules or plaques and scales. Psoriasis is the most well-known example. It's a chronic, immune-mediated, relapsing, proliferative inflammatory disorder affecting the skin, scalp, and nails, and it can also be associated with arthritis, psoriatic arthritis. The underlying pathophysiology involves a complex interplay between genetic factors and environmental triggers, leading to dysregulation of the immune system, particularly involving T cells and cytokines like TNF-alpha and interleukins. This drives inflammation and causes hyperproliferation of keratinocytes. They reproduce much too quickly. This results in a dramatically shortened epidermal turnover time, from the normal 26-30 days down to just 3 to 4 days in psoriatic lesions. This rapid shedding leads to thickening of the epidermis and dermis and the formation of the characteristic well-demarcated erythematous red plaques covered with thick, silvery white scales. Common sites include elbows, knees, scalp, and the lower back, but it can be widespread. Pityriasis rosea is a self-limiting inflammatory disorder, thought possibly to have a viral trigger, perhaps related to human herpes viruses 6 or 7. It typically begins with a single, larger oval patch called a Herald patch, usually on the trunk. This is followed a week or two later by the eruption of numerous smaller, oval, pinkish lesions with fine scales, often arranged in a characteristic Christmas tree or drooping pine tree pattern on the trunk and proximal extremities. It usually resolves spontaneously within 6 to 8 weeks. Lichen planus, LP, is a relatively common benign autoimmune inflammatory disorder that can affect the skin, mucous membranes, especially the mouth, hair, and nails. The classic skin lesions are the 4 Ps, purple, polygonal, poritic papules, and plaques. They often occur on the wrists, ankles, and lower back. Wickham stria, fine white lines on the surface of papules or oral lesions, are also characteristic. The cause is unknown, but thought to involve a T-cell-mediated attack against basal keratinocytes.
What about lupus affecting the skin?
Lupus erythematosus is a systemic autoimmune disease where the body produces autoantibodies against its own nuclear components, leading to inflammation and tissue damage in various organs. The skin is frequently affected. Discoid lupus erythematosus, DLE, is a form largely restricted to the skin. It typically presents with well-demarcated erythematous scaling plaques, often with follicular plugging and central atrophy or scarring. Lesions commonly occur in sun-exposed areas, especially the face, sometimes in a butterfly pattern across the nose and cheeks. Scalp can cause scarring, hair loss, and ears. In systemic lupus erythematosus, SLE, skin manifestations are very common, but are part of a broader systemic illness involving joints, kidneys, heart, lungs, brain, and blood cells. The classic butterfly rash, malar rash, is common in SLE, but various other rashes can occur. Autoantibodies and immune complex deposition contribute to the widespread tissue damage.
Okay, and some reactions seem related to drugs or infections like erythema multiforme or SJSN.
Yes, those represent a spectrum of hypersensitivity reactions affecting the skin and mucous membranes. Erythema multiforme, EM, is an acute self-limiting syndrome often triggered by infections, especially herpes simplex virus, or sometimes drugs. It's characterized by the abrupt onset of target or iris lesions, which typically have three concentric zones: a dusky or purpuric center, surrounded by a pale edematous ring, and then an erythematous outer ring. Lesions often appear symmetrically on the extremities, palms, and soles, and may involve the mucous membranes, mouth, eyes, genitals. Stevens-Johnson syndrome, SJS, and toxic epidermal necrolysis, T or N, are now considered variants of the same severe, life-threatening mucocutaneous disease, primarily triggered by medications. Common culprits include certain antibiotics like sulfonamides, anticonvulsants, allopurinol, and NSAIDs. They represent a severe type IV hypersensitivity reaction leading to widespread apoptosis, programmed cell death, of keratinocytes.
How do SJS and TEN differ?
They are differentiated primarily by the percentage of body surface area, BSA, affected by blistering and epidermal detachment, sloughing. SJS involves less than 10% detachment, 10 involves more than 30% BSA detachment, and the overlap zone, 10-30%, is termed SJS-10 overlap. Both present with fever, malaise, and then the rapid onset of painful, dusky red or purpuric macules that coalesce and progress to flaccid blisters and widespread epidermal detachment, resembling a severe burn. Mucous membrane involvement, mouth, eyes, genitals, is typically severe and causes significant pain, erosions, and potential long-term complications like blindness or strictures. SJSN are medical emergencies requiring immediate cessation of the offending drug, hospitalization, often in a burn unit, intensive supportive care, fluid and electrolyte management, nutritional support, pain control, wound care, and management of complications like infection and organ damage. Mortality rates are significant, especially for 10.
Wow, those sound incredibly serious. Okay, let's move on to skin infections, which are incredibly common, ranging from everyday annoyances to potentially serious conditions. What are the main categories we should know about?
Skin infections are indeed extremely prevalent and can be caused by a wide variety of pathogens: bacteria, viruses, fungi, and even parasites. While often localized, they always have the potential for more serious local complications like abscess formation or deeper tissue spread, or even systemic spread, bacteremia, sepsis, particularly in individuals with weakened immune systems. Let's start with common bacterial infections. Superficial infections often involve hair follicles. Folliculitis is inflammation of the hair follicle, often appearing as small pustules centered on a hair. A furuncle, or boil, is a deeper infection of a hair follicle, essentially an abscess, typically caused by Staphylococcus aureus. It starts as a tender, red nodule that enlarges and may eventually drain pus. A carbuncle is a larger, deeper lesion formed by the coalescence of several infected furuncles, often occurring on the back of the neck. Cellulitis is a common, acute, spreading infection of the dermis and subcutaneous tissue. It's usually caused by S. aureus or group A streptococci entering through a break in the skin, like a cut, insect bite, or ulcer. It presents as a localized area of erythema, redness, warmth, swelling, and tenderness, often with poorly defined borders. It can sometimes be associated with fever and chills. It's important to differentiate cellulitis from necrotizing fasciitis, a much rarer but life-threatening, rapidly spreading infection of the deep fascia that requires emergency surgical debridement. Erysipelas is a specific type of superficial cellulitis involving the upper dermis and superficial lymphatics, most often caused by group A streptococci. It typically presents as a bright red, hot, sharply demarcated, raised lesion, often on the face or lower legs, St. Anthony's fire. Impetigo is a highly contagious superficial bacterial infection common in children, usually caused by S. aureus or streptococci. It's characterized by vesicles or pustules that rupture and form thick, adherent golden yellow or honey-colored crusts. We should also mention Lyme disease. While it's a systemic illness, its earliest and most recognizable sign is often dermatological. It's caused by the Spirochete bacterium Borrelia burgdorferi, transmitted by infected ixodes, ticks, deer ticks. The characteristic initial lesion, occurring in about 70–80% of cases, is erythema migrans, EM, the classic bullseye rash. It starts as a red papule at the site of the tick bite and gradually expands over days to weeks, often with central clearing, forming a large annular lesion. If untreated, the infection can disseminate, causing secondary rashes, neurological problems like Bell's palsy, carditis, myalgias, arthralgias, and eventually chronic arthritis or encephalopathy.
Okay, lots of bacterial culprits. What about common viral skin infections?
Viral infections are also very common causes of skin lesions. Herpes simplex virus, HSV, comes in two main types. HSV1, which traditionally causes oral infections, cold sores or fever blisters, or labial herpes, but can also cause genital herpes, and HSV2, which is the most common cause of genital herpes, but can also cause oral infections. Both cause recurrent outbreaks characterized by clusters of small, painful vesicles on an erythematous base. The key feature of herpes viruses is their ability to establish lifelong latency within sensory nerve ganglia. The virus can then reactivate periodically, often triggered by stress, illness, sun exposure, or immunosuppression, causing recurrent lesions at or near the original site. Herpes zoster, shingles, is caused by the reactivation of the varicella zoster virus, VZV, the same virus that causes chickenpox, varicella. After a primary chickenpox infection, VZV establishes latency in dorsal root ganglia along the spine. Years or decades later, often due to declining immunity, like with age or illness, the virus can reactivate and travel down a sensory nerve to the skin supplied by that nerve, a dermatome. This causes a characteristic unilateral painful vesicular eruption along that dermatome. The pain can be severe and sometimes precedes the rash. A major complication, especially in older adults, is postherpetic neuralgia, PHN, persistent nerve pain that can last for months or even years after the rash resolves. Vaccination against shingles is available and recommended for older adults. Warts, verrucae, are benign epidermal growths caused by various types of human papillomavirus, HPV. They are very common, especially in children, and are transmitted by direct contact or autoinoculation. There are different clinical types, including common warts, verruca vulgaris, plantar warts on the soles of the feet, flat warts, and genital warts, condyloma acuminatum, which are sexually transmitted.
And fungal infections. Athlete's foot and ringworm seem common.
Yes. Superficial fungal infections of the skin, hair, and nails, often called tinea infections or dermatophytoses, are extremely common. They are caused by dermatophytes, fungi that live on keratin. They are typically classified by the location on the body. Tinea pedis, athlete's foot affecting the feet, especially between the toes. Tinea corporis, ringworm affecting the body, often presenting as annular lesions with raised borders and central clearing. Tinea cruris, jock itch affecting the groin. Tinea capitis affecting the scalp can cause hair loss. Tinea unguium, onychomycosis affecting the nails. Diagnosis is often clinical but can be confirmed by microscopic examination, KOH-GREP, or fungal culture of skin scrapings or nail clippings. Treatment usually involves topical or oral antifungal medications. Candidiasis is another type of common fungal infection caused by yeast, most commonly Candida albicans. Candida is part of the normal flora of the skin, mouth, gut, and vagina, but it can overgrow and cause infection under certain conditions like moisture, warmth, antibiotic use, or immunosuppression. It often affects skin folds, intertrigo, the mouth, thrush, white patches, the vagina yeast infection, or around the nails, paronychia.
Okay, we've covered infections. What about other significant skin conditions, including tumors, which can range from completely benign growths to potentially life-threatening malignancies?
Right. Beyond infections and inflammatory disorders, there's a wide range of other conditions. Let's briefly mention scleroderma. This is a chronic connective tissue disease characterized by sclerosis, which means hardening and thickening, primarily of the skin, but it can also affect internal organs. There's localized scleroderma, morphia, which mainly affects the skin, causing patches of hardened, shiny skin. And then there's systemic scleroderma, systemic sclerosis, which is more serious and involves widespread skin thickening, along with aggressive fibrosis, scarring in internal organs like the esophagus, lungs, kidneys, and heart. It's an autoimmune disease involving excessive collagen deposition. Now, turning to skin tumors, these are extremely common, and the vast majority are benign. But it's crucial to differentiate them from malignant tumors. Common benign tumors include seborrheic keratosis, SK. These are very common benign proliferations of epidermal cells, often appearing in middle-aged or older individuals. They look like waxy or greasy, slightly elevated, stuck on papules or plaques, usually brown or black, often on the trunk, face, or scalp. They are harmless but can sometimes be mistaken for melanoma. Keratoacanthoma, KA. This is a relatively common, rapidly growing tumor that resembles squamous cell carcinoma clinically and pathologically. However, KAs often have a characteristic crater-like center filled with keratin and have a tendency to involute and resolve spontaneously over several months, though excision is often recommended because distinguishing them from SCC can be difficult. They typically occur on sun-exposed skin. Nevus, commonly known as moles. These are benign, localized proliferations of melanocytes, the pigment-producing cells. They can be present at birth, congenital nevus, or appeared later, acquired nevus. Most moles are completely harmless. However, certain types of nevus, like dysplastic or atypical nevus, have an increased potential to transform into malignant melanoma, and new or changing moles always warrant evaluation.
That's where the ABCDE rule comes in, right?
Exactly. The ABCD rule is a simple mnemonic used by both clinicians and the public to help identify potentially suspicious pigmented lesions that might be melanoma. A for asymmetry, one half doesn't match the other. B for border irregularity, edges are ragged, notched, or blurred. C for color variation, not uniform in color, shades of brown, black, tan, sometimes red, white, or blue. D for diameter greater than 6 millimeters, about the size of a pencil eraser, although melanomas can be smaller. E for elevation, or more recently and perhaps more importantly, evolving, any change in size, shape, color, elevation, or symptoms like itching or bleeding. Any lesion exhibiting these features should be evaluated promptly by a healthcare professional, often requiring a biopsy.
Okay, ABCDE. Crucial for melanoma surveillance. Now, what about the malignant skin tumors?
Malignant skin tumors, or skin cancers, are broadly divided into melanoma and non-melanoma skin cancers. Chronic exposure to UV radiation from the sun, or tanning beds, is the primary cause of most skin cancers. The non-melanoma skin cancers are much more common. Basal cell carcinoma, BCC, is the most common type of cancer in humans, period. It arises from basal cells in the epidermis. It typically occurs on sun-exposed areas like the face, ears, neck, and upper back. The classic appearance is a pearly or waxy papule or nodule, often with small dilated blood vessels, telangiectasias, on the surface, and sometimes with a depressed or ulcerated center and rolled borders. BCC grows slowly, is locally invasive, but very rarely metastasizes. Treatment is usually curative with surgical excision or other local therapies. Squamous cell carcinoma, SCC, is the second most common skin cancer. It arises from keratinocytes in the epidermis. It also typically occurs on sun-exposed skin, often arising from precursor lesions called actinic keratoses, rough, scaly patches on sun-damaged skin. SCC often appears as a firm, red papule, nodule, or plaque, sometimes with a scaly, crusted, or ulcerated surface. SCC grows faster than BCC and has a higher potential to metastasize, although metastasis is still relatively uncommon for most cutaneous SCCs. Treatment usually involves surgical excision. Then there's cutaneous melanoma. This is the most serious form of skin cancer because it has a high propensity to metastasize early to lymph nodes and distant organs if not detected and treated promptly. It arises from melanocytes. While less common than BCC or SCC, melanoma accounts for the vast majority of skin cancer deaths. As we discussed, vigilance for changing moles using the ABCDE rule is critical for early detection. There are different clinical subtypes of melanoma: superficial spreading, nodular, lentigo maligna, acrolentiginous. Treatment for localized melanoma involves wide surgical excision. For metastatic melanoma, treatments have advanced significantly with the advent of targeted therapies and immunotherapies.
Are there other, less common skin malignancies?
Yes, a few others are worth mentioning. Kaposi sarcoma, KS, is a vascular malignancy that is strongly associated with human herpes virus 8, HHV8 infection, and immunodeficiency, particularly AIDS. Before the AIDS epidemic, it was mainly seen as a slow-growing tumor in elderly men of Mediterranean or Eastern European descent. In AIDS-related KS, lesions are often multiple, widespread, and more aggressive. They typically appear as red, purple, or brown macules, papules, plaques, or nodules, often on the lower extremities in classic KS, or more symmetrically on the upper body, face, and oral mucosa in AIDS-related forms. Treatment depends on the type and extent, but may involve local therapies, chemotherapy, or improving immune status, for example, with antiretroviral therapy for AIDS-related KS. Primary cutaneous lymphomas are lymphomas, cancers of lymphocytes, that originate in the skin without evidence of disease elsewhere at the time of diagnosis. They can be derived from T cells or B cells. The most common type is mycosis fungoides, a cutaneous T-cell lymphoma, CTCL, which typically progresses slowly through patch, plaque, and tumor stages.
Okay. Finally, let's touch upon burns, which represent a major, often devastating injury to the integumentary system.
Burns are indeed a major form of trauma, causing significant damage to the skin and potentially leading to profound systemic consequences, depending on their depth and extent. Burns are classified based on the depth of tissue injury. First-degree burns, superficial burns, involve only the epidermis. They are characterized by erythema, redness, pain, and mild swelling, but no blistering, like a typical sunburn. They usually heal in a few days without scarring. Second-degree burns, partial thickness burns, involve the epidermis and part of the dermis. They are further divided into superficial partial thickness burns. These involve the epidermis and the upper papillary dermis. They are typically very painful, appear red and moist, and characteristically form blisters. They usually heal in 1-3 weeks, often with minimal scarring but potential pigment changes. Deep, partial thickness burns. These extend deeper into the reticular dermis. They may appear waxy white, mottled red and white, or dry. Blisters may or may not be present. Sensation may be reduced, and they are less painful than superficial partial thickness burns. Healing takes longer, 3 to 8 weeks, is prone to significant scarring and contracture formation, and may require skin grafting. Third-degree burns, full-thickness burns, destroy the entire epidermis and dermis, extending into the subcutaneous tissue. The skin appears dry, leathery, and may be white, brown, or charred black. Since nerve endings are destroyed, these burns are typically painless or anesthetic to light touch in the center. They cannot heal spontaneously except by wound contraction at the edges and always require skin grafting. Fourth-degree burns are even deeper, extending beyond the skin into underlying muscle, tendon, or bone.
How is the extent of a burn assessed?
The extent or size of a burn is usually estimated as a percentage of the total body surface area (TBSA) affected. The rule of nines is a commonly used method for a quick estimation in adults, dividing the body into regions that represent multiples of 9%. For example, each arm is 9%, each leg is 18%, head and neck are 9%, anterior trunk is 18%, posterior trunk is 18%, perineum is 1%. For children, modified charts like the Lund-Browder chart are used because their body proportions are different.
And large burns cause problems beyond just the skin damage, right?
Oh, absolutely. Major burns, generally defined as those covering more than 20% TBSA, or less in children and older adults, trigger a profound systemic inflammatory response with major physiological consequences. The immediate life-threatening issue is burn shock. This is a complex combination of distributive and hypovolemic shock. The intense inflammation causes a massive increase in capillary permeability, leading to large amounts of fluid shifting from the bloodstream into the interstitial space, third spacing, causing edema and intravascular volume depletion. This requires immediate and aggressive intravenous fluid resuscitation based on formulas like the Parkland formula. Following the initial shock phase, patients with major burns enter a prolonged hypermetabolic response. Their metabolic rate can increase dramatically, leading to increased oxygen consumption, catabolism, breakdown of muscle protein for energy, hyperglycemia, high blood sugar, due to insulin resistance, and significant nutritional demands. This hypermetabolic state can persist for many months, even over a year after the initial injury. There's also a significant immunologic response to major burns, often leading to profound immunosuppression, which greatly increases the risk of life-threatening infections and sepsis, a major cause of mortality in burn patients. Treatment of major burns is incredibly complex and requires specialized care in a burn center. It involves meticulous fluid resuscitation, wound care, including debridement of dead tissue and skin grafting, aggressive infection control, pain management, nutritional support, physical therapy to prevent contractures, and psychosocial support.
That sounds incredibly intensive. To wrap up our discussion on the integumentary system then, what about common hair and nail disorders that people might encounter?
Right. Hair and nail disorders are also part of dermatology and can be quite distressing for patients. For hair, alopecia is the general medical term for hair loss. There are many different types and causes. Androgenic alopecia is the most common type. This is hormonally influenced, genetically determined hair loss, manifesting as male pattern baldness in men, receding hairline, thinning crown, and female pattern hair loss in women, diffuse thinning over the top of the scalp. Alopecia areata is an autoimmune condition where the immune system attacks hair follicles, causing sudden onset of smooth circular patches of complete hair loss, usually on the scalp but sometimes elsewhere. In most cases, the hair eventually regrows, but it can sometimes be extensive. Alopecia totalis, loss of all scalp hair, or alopecia universalis, loss of all body hair. Other causes of hair loss include telogen effluvium, diffuse shedding, often triggered by stress, illness, or hormonal changes, traction alopecia from tight hairstyles, fungal infections, tinea capitis, and hair shaft abnormalities. Hirsutism refers to excessive growth of coarse, dark, male pattern hair like on the face, chest, back in women. While it can be normal for some individuals based on ethnicity, it can also be a sign of underlying hormonal imbalances, most commonly polycystic ovarian syndrome, PCOS, or other conditions causing excess androgen production. For nails, paronychia is inflammation of the skin folds surrounding the nail plate, the cuticle area. Acute paronychia is usually caused by a bacterial infection, often S. aureus, after minor trauma, while chronic paronychia is often related to persistent moisture exposure and may involve fungal infection, candida. Onychomycosis is a fungal infection of the nail plate itself, Tinea unguium. It causes the nails, most often toenails, to become thickened, brittle, discolored, yellowish or whitish, and sometimes crumbly or separated from the nail bed. It can be difficult to treat, often requiring long courses of oral antifungal medications.
Wow, okay. We have truly taken a deep dive today, covering an incredible amount of ground on both the musculoskeletal and the integumentary systems. We started with the foundations, the structure and function of bones, joints, muscles, understanding their dynamic nature, that constant remodeling and interaction needed for movement and support. And then we explored the skin, our largest organ, looking at its protective layers and its really surprisingly diverse roles in our overall health.
Yes, and from that foundation, we then explored a really vast array of disorders. We categorized them by how they affect adults versus children, seeing both similarities and important differences. We looked at how fractures heal, the complexities of different types of arthritis, the wear and tear of osteoarthritis versus the autoimmune attack in rheumatoid arthritis. We also highlighted the critical dangers of acute conditions like rhabdomyolysis and compartment syndrome. And importantly, we shed light on those unique challenges in pediatric musculoskeletal health, from congenital issues like clubfoot and developmental hip dysplasia to serious genetic disorders like Duchenne muscular dystrophy. Finally, we navigated the wide spectrum of skin conditions, everything from common inflammatory disorders like eczema and psoriasis, numerous bacterial, viral, and fungal infections, all the way to life-threatening burns and the different types of benign and malignant skin tumors, really emphasizing the skin's vital role as both a barrier and, quite often, a mirror reflecting our internal health.
So, to try and bring it all together, what's the fundamental takeaway from this intricate journey through the body's framework and outer shield? I think for me, it means that these systems, which we often just take for granted as we move through our day, are truly marvels of biological engineering. They're constantly adapting, repairing, maintaining themselves in this incredible dynamic balance. But, as we saw, they're also vulnerable to a fascinating and sometimes daunting array of pathologies. Each condition has its own intricate mechanisms, its own clinical presentation, its own treatment challenges. And understanding these deep dives, it's not just about memorizing lists of facts or disease names, is it? It's really about appreciating the incredible resilience and complexity of the human body and that constant delicate balance required for health. As you, our listeners, go about your day, maybe take a moment to think about that silent symphony. All those cells and tissues working tirelessly just to keep you moving, protected, and interacting with your environment. What new questions does this understanding spark for you? Perhaps about the interconnectedness of your own body. How a seemingly small issue in one area, maybe a skin reaction or a joint ache, could potentially ripple through an entire system. That's something to mull over. We want to give a huge thank you to the Last Minute Lecture team for providing the incredible resources based on Understanding Pathophysiology that made this deep dive possible today. We sincerely hope this has been an insightful and genuinely valuable session for you. Keep learning, keep exploring, and we'll catch you on the next deep dive.